around 5 lectures. Yeah, I think you guys have had around 5 lectures in nephrology, which is glomerular disease, electrolyte disturbances, and acid-base problems. And so we'll just run through each part. It's a section review. So we'll start with glomerular diseases, then electrolytes, then acid-base. And how this work is, I'll basically read the scenario. You guys will have some time to answer questions, and then we'll just go through the question, okay? Okay, so this is the first one. Okay, so a 6-year-old boy is okay. A 6-year-old boy is brought to the physician because of increased swelling around his eyes for the past 3 days. During this period, he has had frothy light yellow urine. He had a sore throat 12 days ago. He appears tired. His temperature is 37, pulse is 90 per minute, and blood pressure is 105/65 millimeters of mercury. Examination shows periorbital edema and pitting edema of the lower extremities. Cardiopulmonary examination shows no abnormalities. Which of the following findings on urinalysis is most likely associated with this patient's condition? So they're asking you, this is a case of nephrotic syndrome. They're basically asking you which of the following are urinary findings you would see in nephrotic syndrome. The answer is okay, so everyone's saying WBC casts. In nephrotic syndrome, you would see something called fatty casts because excess lipids are leaking out into the urine, and as they're passing through the renal tubule, they form casts. Okay, so the answer is D. So just to recap, hyaline casts are something seen after exercise or dehydration. Red cell casts are seen in nephritic syndromes. White cell casts are seen in infections or inflammation or allergies, right? So pyelonephritis, which is infection of the kidney, you would see white cell casts, and interstitial nephritis, which is usually an allergic reaction to a drug. It usually causes white cell casts and eosinophils in urine, okay? Tubular cell casts are seen in acute tubular necrosis. This is important. Muddy brown granular casts are seen in acute tubular necrosis, which is a form of acute kidney injury. And waxy casts are seen in end-stage kidney disease. This is the next question. A 32-year-old woman comes to the physician because of fatigue, lethargy, and swelling of the lower legs for 2 months. She has pitting edema. She reports recurrent episodes of pain in both wrists, her right knee, and her right ankle in the past year. She has skin problems that's aggravated by exposure to sunlight. Examination shows pretibial edema bilaterally and periorbital edema. There are erythematous patches with scaling on both cheeks. Relevant lab studies are shown. Serum albumin is low, 2.6. She has hyperlipidemia, hypercholesterolemia, hypertriglyceridemia, and proteinuria. So she has nephrotic syndrome. Histopathological examination of a renal biopsy specimen is most likely to show which of the following? Okay, so this patient, they're pointing you towards the fact that she has lupus. She has photosensitivity and she has a butterfly rash on both cheeks. And then they're asking you what would lupus cause in the kidney, or which kind of lupus which kind of kidney disease would system SLE cause? And they are pointing towards a nephrotic syndrome because of the hypertriglyceridemia, because of the 4+ proteinuria. This would cause thickened capillary loops in the kidney. So as you know, there's 6 types of lupus nephritis. Type 4 is the most common, which is a nephritic syndrome. Lupus usually causes nephritic syndrome, but type 5 lupus nephritis causes membranous nephropathy, okay, which manifests with thickened capillary loops. Okay, that's the classic case of lupus nephritis type 5, which is membranous nephropathy. Any questions regarding this? Okay. All right. A 28-year-old woman comes to the emergency department. Could you remind me of what C is? Segmental sclerosis. This is a case of nephrotic syndrome called FSGS, or focal segmental glomerulosclerosis. It's usually seen in African American patients or in patients who are HIV positive or patients who have had a history of heroin abuse. Okay, so that's not this case. This is SLE causing lupus nephritis type 5. So this question, a 28-year-old woman comes to the ED 4 hours after sudden onset of bilateral flank pain and nausea. During this time, she also noticed blood in her urine, gradually worsening swelling of her legs. Over the past 2 months, she has noticed swelling around her eyes and both her legs and has also complained of weight gain. She is vitally stable. Physical examination shows a distended abdomen, bilateral flank tenderness, and 2+ pitting edema of the lower extremities. Laboratory studies are shown. So she has an elevated lactate, an elevated BUN and creatinine, which shows basically acute kidney injury. All right. 2 weeks later, her creatinine and BUN are back to normal. Which of the following is the most likely diagnosis? Okay, so this is a case of, again, nephrotic syndrome because she had uh, worsening swelling of her legs and also complained of weight gain, and she has periorbital edema. So this is a case of nephrotic syndrome, C and D, C and D. Okay. Then, because of this nephrotic syndrome, this person developed renal vein thrombosis. The classic presentation of renal vein thrombosis is flank tenderness and hematuria. Okay, and as you know, hypercoagulability is is one of the associations of nephrotic syndrome, particularly membranous nephropathy. And I'm emphasizing this because Dr. Khalid loves to ask this. He asked us this during our exam, which is that all nephrotic syndromes, because they lose clotting factors in their urine, specifically antithrombin 3, they're predisposed to blood clots. But not all nephrotic syndromes manifest with hypercoagulability. Membranous nephropathy is the most strongly associated with hypercoagulability, specifically renal vein thrombosis. So you might see a scenario in the exam where it's a confirmed case of membranous nephropathy, and then the patient develops flank tenderness and hematuria. Her BUN and creatinine are high and LDH is high. This is a classic case of renal vein thrombosis, right? In males, renal vein thrombosis affecting the left renal vein would also cause a varicocele because the left gonadal vein drains into the left renal vein, and so there's renal vein thrombosis because of membranous nephropathy that will cause left-sided varicocele in males, all right? So just remember membranous nephropathy associated with blood clots. This is a classic case again. A 35-year-old African-American man comes to the physician complaining of 2 weeks of abdominal distension. He has been in drug rehabilitation program for 2 years due to prior heroin abuse. He has a recent viral hepatitis and HIV profiles were negative. He is vitally stable, but he has a bit of hypertension. The patient is obese with a BMI of 40 kilograms per meter squared. Examination shows periorbital edema, ascites, and 2+ pitting edema in both legs going up to the knees. Breath sounds are decreased at the right lung base. 24-hour urinary protein excretion shows a protein excretion of 7.5 grams. Which of the following is most likely present on kidney biopsy? Okay, yeah, good, yeah. So this is a classic case of focal segmental glomerulosclerosis. Usually in African Americans, history of heroin abuse or HIV positive and or obese, okay? This is the classic case of FSGS. Again, focal segmental glomerulosclerosis basically means less than 50% of the glomeruli are involved, and segmental basically means that of the involved glomeruli, less than 50% of them are involved. Okay, so each individual glomerulus, less than 50% of it is involved. That's segmental. Good. So this is a bit more difficult. A 38-year-old woman comes to the physician because of a 5-week history of abdominal distension and swelling of her face and lower extremities. So again, all nephritic or nephrotic syndromes, they basically cause generalized edema, ascites, abdominal distension, lower limb swelling, and periorbital edema. Okay. Past medical history reveals a diagnosis of Crohn's disease 16 years ago with multiple flares. 1 year ago, she underwent carpal tunnel release surgery for median nerve compression. Current medications include immunosuppressants, azathioprine, and loperamide. She doesn't smoke, drink alcohol, or use illicit drugs. She's hypertensive. Physical examination, again, the generalized edema, generalized pitting edema, moderate ascites and hepatosplenomegaly. Serum albumin is low. She has high cholesterol and normal bilirubin. A urine dipstick shows 4+ proteinuria, which is diagnostic of nephrotic syndrome, all right? A renal biopsy is most likely to show which of the following findings? Any ideas? Okay, so B. All right, so let's go through it. This patient has a long-standing inflammatory disease, which is Crohn's disease. Now she's developing nephrotic syndrome, right? So A says linear IgG deposits with crescents on light microscopy. This basically signifies anti-GBM disease or Goodpasture syndrome. It usually manifests with nephritic syndrome, all right? Glomerular basement membrane thickening with subepithelial dense deposits on electron microscopy. This is membranoproliferative glomerulonephritis. Again, usually a nephritic syndrome, but also nephrotic, is associated with either complement pathway activation or autoimmune diseases. Now, this is the right answer. C. Mesangial deposits that exhibit apple green birefringence on polarized light microscopy. So this patient has a chronic inflammatory disease which generates a protein called AA amyloid. And amyloidosis most commonly involves the kidney and it most commonly causes nephrotic syndrome. All right. So in the exam, if you see a patient with either Crohn's disease or rheumatoid arthritis is a famous one, and they start developing nephrotic syndrome, this is a classic case of amyloidosis, right? Good. So D talks about nodular sclerosis within glomeruli on light microscopy. This is diabetes. This patient has no history of diabetes. Segmental sclerosis of glomeruli on LM and podocyte foot effacement of podocyte foot process effacement on electron microscopy. This is FSGS, okay? Another thing which hints you towards amyloidosis is that this patient underwent carpal tunnel release surgery. So because amyloid is infiltrating not only the kidney but also other tissues, they can have carpal tunnel syndrome, they can have enlargement of the tongue as well, all right? The chronic inflammatory disease associated with nephrotic syndrome equals amyloidosis. Good. So now we're done with the nephrotic syndromes. These next few questions deal with nephritic syndromes. So a 40-year-old woman comes to the physician because of a 1-week history of fatigue, dark urine, and a feeling of heaviness in her legs. 2 weeks ago, she returned from Brazil, where she spent most of her days exploring the city on foot. She has also gained 3 kilograms. She has lupus. Her only medication is hydroxychloroquine. She's afebrile, normal pulse, but slightly hypertensive. Not even slightly, very hypertensive. Physical examination shows 2+ pretibial edema bilaterally. Urinalysis is shown in the table. Which of the following is the most likely cause of this patient's leg findings? Now, she has blood in her urine 3+, so she has hematuria. She doesn't have a nephrotic syndrome because proteins are only 1+. She has RBCs in urine with dysmorphic features, and she has RBC casts, which is characteristic of nephritic syndrome, right? Then they're asking which of the following is the most likely cause of this patient's edema? D. No. So nephritic syndrome and nephrotic syndrome, they both cause edema. They both cause bilateral lower limb edema. They both cause periorbital edema. They both cause ascites. The mechanism is completely different. In nephrotic syndrome, you have loss of albumin in urine. This decreases plasma oncotic pressure, which gives rise to edema. So renal protein loss, or D, would be right if this case was a case of nephrotic syndrome, all right? But this is a case of nephritic syndrome. In nephritic syndrome, you have damage to the glomerulus, and that decreases GFR and renal blood flow. That activates the renin-angiotensin-aldosterone system, which causes sodium reabsorption. And sodium reabsorption leads to blood volume increase, which causes edema, okay? So in nephrotic syndrome, the mechanism of edema is protein loss or albumin loss. In nephritic syndrome, it's activation of the RAS system and salt retention. So the answer is C. Okay, so this is important for you to know. This is a case of a 37-year-old woman Coming to the office, I can't see this properly. Okay. So this is a 37-year-old woman, again, coming for the past 2 months. She has also felt excessively tired and has achy pain in her hands we had never discussed this in class before. So you never discussed whether nephritic or nephrotic syndromes, the mechanism by which they cause edema? Okay. Um, I would have thought you guys would have discussed that. Okay. This is a case of edema again. She has felt tired and has achy pains in her hands. The patient reports occasional respiratory illnesses and minor aches and pains. She has no chronic medical conditions and takes no medication. She is afebrile, slightly hypertensive again. Um, okay. So she's afebrile, she's hypertensive, and she has a normal pulse. So in any nephritic syndrome scenario, you would have hypertension because the renin-angiotensin-aldosterone system is being activated and it's causing blood volume expansion. A physical examination shows normal JVP, dullness, and decreased breath sounds at the lower left lung base, which basically indicates pleural effusion. She has bilateral lower extremity pitching edema. Bilateral finger joints and wrists are mildly swollen and tender to palpation. So she has arthritis, okay? Laboratory studies reveal anemia, thrombocytopenia, and a rise in serum creatinine because of the decrease in GFR because of nephritic syndrome. A peripheral blood smear is normal. Urinalysis is positive for proteinuria and hematuria. Which of the following is most likely involved in the pathogenesis of this patient's renal condition? B, yes. So this is again a case of a woman in reproductive age, which is the classic scenario of an autoimmune disease, developing nephritic syndrome. She has other arthritis-related findings of her fingers. She has pleural effusions, and she has thrombocytopenia, and she has anemia. Lupus causes all these things, and lupus also causes nephritic syndrome. So the answer is B, formation of anti-double-stranded DNA immune complexes. Okay. Filtration of excessive free light chains, again, that reverts to amyloidosis. This refers to post-streptococcal glomerular nephritis. She has no history of a skin infection. Ischemia and infarction of the renal medulla. This refers to renal papillary necrosis. This case isn't that either. Okay, good. So this is lupus. So in lupus, again, they would give you some kind of systemic presentation. They would give you the rash, they would give you photosensitivity, they would give you nasopharyngeal symptoms or ulcers. They would give you pericarditis or pericardial effusions or pleuritis or pleural effusions. They would give you arthritis and they would give you a glomerular disease. Okay. So if you see such a systemic presentation, always keep lupus in mind. This specific clinical scenario was nephritic syndrome, which is the most common case of lupus nephritis, which is type 4. Okay, diffuse proliferative glomerulonephritis. Good. This is a 15-year-old boy who comes to the physician because his urine has been pink since this morning. During the past 2 days, he has had a sore throat and difficulty swallowing. Okay, history of sore throat during the past 2 days. He also reports having low-grade fever. There is no pain with urination. He has had two similar episodes of sore throat followed by pink urine over the past 2 years. He is febrile. He is not tachycardic. He is slightly hypertensive, you could say stage 1. Serum BUN and creatinine are high. Urinary findings are shown in the table. So he has hematuria 3 plus. He doesn't have nephrotic syndrome, is only 1 plus proteinuria. He has RBCs with dysmorphic features and RBC casts, which is classical for nephritic syndrome. And on oral examination, he shows an erythematous pharynx and enlarged tonsils. The remainder of the examination shows no abnormalities. A renal biopsy is most likely to show which of the following findings. So post-infectious, he's developing some sort of nephritic syndrome. What would be seen on microscopy? Okay, good. So there's two diseases you always need to differentiate. One is IgA nephropathy, and one is post-streptococcal glomerulonephritis. Okay, The key to differentiating the two is timing. Post-streptococcal glomerulonephritis manifests 2 to 3 weeks after the infection. It's either a throat or a skin infection, okay? But 2 to 3 weeks. IgA nephropathy manifests within 2 to 3 days of the infection. So the term is synpharyngitic, okay? IgA nephropathy is synpharyngitic. It manifests with the infection. So the correct answer would be IgA mesangial deposition. B would be post-streptococcal glomerulonephritis, okay? So this is the key again. IgA nephropathy, usually within 5 days of the upper respiratory tract infection, is usually seen in adults, but it can be seen in children, and as in this case, recurrent gross hematuria. Serum complement is normal. Usually there are mesangial IgA deposits seen on kidney biopsy. It's usually benign, okay? But on the other hand, post-infectious glomerulonephritis is usually 2 to 3 weeks after the infection. It's more common in children. Adults can be asymptomatic or develop acute nephritic syndrome. The classical lab studies you would see are low complement, elevated antibody titers against ASO and or anti-DNase B titers, and kidney biopsy would show subepithelial humps consisting of C3 complement proteins. Okay, good prognosis in children, bad prognosis in adults. Good. So this is the summary of all the nephrotic syndromes. Okay, minimal change disease. The classical scenario you should keep in mind is a child with sudden onset of full-blown nephrotic syndrome, usually associated with allergies or viral infections. In adults, is associated with Hodgkin's lymphoma or NSAID use. The good thing about minimal change disease is that it's very, very responsive to steroids, okay? If it's not responsive to steroids, it's called FSGS. It's usually associated with podocyte mutations in primary disease. In adults, these are usually African Americans, or the case scenario would be an African American, history of heroin abuse, HIV infection, obesity, also associated with podocyte mutations, okay? Membranous nephropathy, the classic case is a middle-aged white person with full-blown nephrotic syndrome, and importantly, particular predisposition to a hypercoagulable state. Classically, renal vein thrombosis causing flank tenderness and hematuria. Membranous nephropathy can be primary or idiopathic. That's associated with anti-phospholipase A2 antibodies. Secondary is associated with tumors, is associated with SLE or chronic hepatitis B or C infection. Okay. Then there are diseases which are outside of the kidney or systemic, which can then involve the kidney. Okay. So these are intrinsic diseases of the kidney, which we just discussed. But then there are systemic diseases which affect the kidney. Amyloidosis is a classic one. It can be AL amyloidosis. These are usually seen in plasma cell disorders like multiple myeloma. And for this, you check serum protein electrophoresis and urine protein electrophoresis as you studied in hemo. Or you can have AA amyloidosis. This is usually seen in response to chronic inflammatory diseases like rheumatoid arthritis or inflammatory bowel disease. Okay, diabetic nephropathy usually begins with high GFR, hyperfiltration injury, progressing to proteinuria. It usually happens over 15 years. Okay, and then that's why diabetes diagnosis precedes diagnosis of nephropathy by years. Membranoproliferative glomerulonephropathy is classically an acute nephritic syndrome, but it can be nephrotic. There are two types. One is immune complex, that's either idiopathic or associated with hepatitis B or C, or with systemic autoimmune diseases like SLE. Then the other type is called C3 glomerulonephritis. This is also called dense deposit disease. These patients have an antibody called C3 nephritic factor, which stabilizes C3 convertase, okay? And this causes alternative complement pathway activation and nephritic syndrome. So these are the classic cases. Associations again for FSGS, remember African American, remember obesity, HIV, heroin. Membranous, remember solid tumors in case of secondary disease. NSAIDs, hepatitis B and C, and SLE. For membranoproliferative, for the immune complex mediated one, remember hepatitis B and C. And for minimal change, in children is usually post-infectious. In adults, remember lymphoma, remember NSAID use, okay? These are the classic nephritic syndrome cases. I won't go through all of them. Just one distinction you must make, and this will be covered in your renal pathology review. Both pouchy immune glomerulonephritis and anti-GBM glomerulonephritis classically present with rapidly progressive glomerulonephritis with crescents on light microscopy. With Wegener's granulomatosis, these patients usually have hemoptysis and they usually have sinusitis symptoms, okay? With anti-GBM disease, these will have pulmonary hemorrhage and hemoptysis. They won't have the sinusitis symptoms, okay? So you may get confused with Wegener's granulomatosis or with anti-GBM. Look for sinusitis-related symptoms and look for arthritis, okay? If these patients have sinusitis, arthritis, fatigue, myalgias, they usually have a vasculitis that points you towards Wegener's. If they only have the RPGN plus hemoptysis, they probably have Goodpasture syndrome, okay? So the investigations you should do for post-infectious GN, you should do an ASO titers, low complement levels would be seen. Anti-GBM would be an anti-GBM antibody with linear deposits on immunofluorescence. Small vessel vasculitis is pouchy immune RPGN. You usually do a P-ANCA in case of Churg, Strauss, or microscopic polyangiitis, or C-ANCA in case of Wegener's. Lupus nephritis, you do ANAs, double-stranded DNA, and complement, okay? So we're finished with glomerular diseases. Any questions related to glomerular diseases? Here, good. The main thing I would emphasize clinically that you probably didn't take in pathology is membranous nephropathy leading to blood clots, okay? Dr. Saleh loves that question. Good. So now, let's move on to electrolytes. A 44-year-old man is brought to the ED 45 minutes after being involved in a high-speed RTA in which he was the restrained driver. On arrival, his pulse is 135, he's tachypnic, he's tachycardic, he's hypotensive. Examination shows an open left tibial fracture with active bleeding, with decreased femoral and pedal pulses bilaterally. A massive transfusion protocol is initiated. An X-ray of the pelvis shows an open pelvic fracture and a left tibial fracture. Laboratory studies are shown in the table. The main one is highlighted here. He has a sodium of 125 milliequivalents per liter, or he has hyponatremia. Which of the following is the most likely explanation for this patient's hyponatremia? Any ideas? Okay, so this patient has low blood volume or he is hypotensive. In terms of physiology, what hypotension does, it activates ADH secretion, and that ADH secretion has two effects. It goes to the distal nephron and causes water reabsorption to maintain serum osmolality, and it binds to its receptors on blood vessels to cause vasoconstriction to maintain blood pressure. So the answer would be D, physiologic ADH secretion. Okay, and this brings us to an important point, which is that your body fluids are basically regulated in two ways. One is blood volume and one is blood osmolality, okay? Blood volume is determined by the amount of sodium in the body. So the more sodium you have, the more volume you will have. The total amount of sodium in the body is controlled by the renin-angiotensin-aldosterone system. On the other hand, you can have regulation of osmolality, which basically is dependent on sodium concentration, not the amount of sodium, the concentration of sodium. And if it's the concentration of sodium, it's always relative to water. Okay. So by regulating water reabsorption or excretion, you regulate plasma sodium concentration, and thereby you regulate osmolality. So water balance determines osmolality. Sodium balance determines blood volume. Sodium balance is controlled by the renin-angiotensin-aldosterone system. Water balance is controlled by ADH. ADH has basically two effects or two stimuli. One is an increase in plasma osmolality. One is a decrease in blood volume. This doesn't happen all the time. It only happens in severe circumstances. But when the patient has a severe decrease in blood volume, this becomes the predominant effect of ADH. So ADH will continue to bind to blood vessels and it will continue to reabsorb water regardless of whether it causes hyponatremia or a decrease in serum osmolality, because its effect to maintain blood pressure is dominant over the effect on osmolality. Okay, good. So again, it's the same case. A 48-year-old man is brought to the ED by his wife because of seizures. During these episodes, he urinated on himself. He is now drowsy and nauseated. He has a history of chronic alcohol use. He has been drinking 15 beers daily for the past 3 years. His last drink was 2 hours ago. He appears lethargic. His vital signs are within normal limits. Physical and neurological examination disclose no other abnormalities. On mental status exam, he is confused and not oriented. Laboratory studies are shown. The important one is this. He has severe hyponatremia, a sodium of less than 112 milliequivalents per liter. The normal serum sodium is 135 to 145. Urgent treatment of this patient's condition puts him at increased risk for which of the following adverse events? E, good. Yeah. So rapid correction of hyponatremia can cause demyelination of corticospinal tract neurons and can lead to something called locked-in syndrome. All right. This condition is called osmotic demyelination or osmotic myelinolysis. So again, when you're correcting hyponatremia, it's always important to correct it slowly, unless the patient has seizures. Okay. What about A? The patient would, so if you're correcting hyponatremia, you would actually be correcting cerebral edema. Hyponatremia leads to cerebral edema. Okay. Hypernatremia or increasing the sodium doesn't lead to cerebral edema. Okay. So if they ask you what is a potential complication of this patient's condition or severe hyponatremia with seizures, one would be cerebral edema. The answer would be cerebral edema. Okay. Good. So this is a quick recap of how to think about hyponatremia. So again, hyponatremia is a decrease in serum sodium below 135. The next step is to check serum osmolality because sodium concentration is the major determinant of serum osmolality. If both are decreased, then you know the that it's a true hyponatremia in the sense that the decrease in sodium is causing the decrease in osmolality. Okay. If you see a hyponatremia in the setting of increased osmolality, serum osmolality, these patients are usually type 2 diabetics who are not well controlled on their medications. They have very, very high blood glucose, around 400-500, and this blood glucose drags water out of cells, and so it dilutes the sodium, which gives you a false impression of hyponatremia, but it is accompanied by an increase in serum osmolality. This is called hypertonic hyponatremia. The other scenario is that you can have a hyponatremia with a normal serum osmolality. This is usually seen in the setting of multiple myeloma, okay, or other paraproteinemias. These are basically elevated proteins in blood, and they give a false impression of hyponatremia. This is also called pseudo-hyponatremia, okay? Now, once you have low osmolality, you know it's a true hyponatremia, right? And I told you that water balance determines sodium concentration. So whenever you think of true hyponatremia, you should think of ADH. If the patient is hypovolemic, the stimulus for ADH would kick in, ADH would be secreted, and it would bind to blood vessels to cause vasoconstriction. At the same time, it would cause water reabsorption and hyponatremia. Okay, so one scenario is that the patient's hypovolemic. In the scenario, they would usually give you that this patient's mucous membranes are dry, or he has decreased pulses or capillary refill, or he's hemorrhaging. In that setting, like the scenario we had previously, this would be a case of hypovolemic hyponatremia, which is normal. And to treat this, you should give fluids, okay? The other scenario is that ADH is being secreted under the impression that you're hypovolemic, but you're not actually hypovolemic. This can happen in nephrotic syndrome, congestive heart failure, and cirrhosis. These conditions cause edema, okay? So you have a lot of fluid in the body, but that fluid is leaking out of blood vessels and going into tissues, causing generalized edema. This decreases the amount of fluid in the blood vessels, and that causes ADH secretion, which causes water reabsorption in urine, and causes hyponatremia, okay? The other scenario is that your volume status is completely normal, and yet you still have ADH secretion. This is called syndrome of inappropriate ADH. You treat it with volume restriction, okay? In all of these cases, ADH is active and urine osmolality would be greater than 100 milliosms per kilogram of water, okay? The other scenario is that you're euvolemic, but your urine osmolality is less than 100 milliosms per kilogram. This means that the kidney is responding normally, or it's not under the influence of ADH. So you're hyponatremic or your serum osmolality is low, and your kidney senses that, and it starts getting rid of the free water. This is usually seen in polydipsia, primary psychogenic polydipsia in patients with psychiatric issues, beer or tea and toast diet. Okay. In this scenario, urine osmolality would be less than 100. So whenever you approach a case of hyponatremia, always look at the serum sodium, then look at the serum osmolality to see whether it's true, pseudo, or hypertonic. If it's true, look at the urine osmolality. If it's greater than 100, you automatically know that it's ADH dependent. Then check the patient's volume status. If the patient's hypovolemic, that makes sense for the ADH to be secreted and cause hyponatremia. If the patient's hypervolemic, he may have heart failure, he may have nephrotic syndrome, he may have cirrhosis. If the patient is euvolemic, this is called SIADH, treat with fluid restriction. Okay? A couple points on treatment of hyponatremia. If it develops in less than 48 hours, or if it's severely symptomatic. By severely symptomatic, it means any CNS symptom. If the patient is altered mental status, he's lethargic, or he's having seizures, you should give hypertonic saline. Okay? But it carries a risk of osmotic demyelination. In any other case of hyponatremia, if it develops in more than 48 hours, if it's non-urgent symptoms, if he doesn't have CNS symptoms, you don't give hypertonic saline, you correct the underlying cause. If it's hypovolemic, give fluids. If it's SIADH, restrict fluids. If it's hypervolemic, give diuretics. Okay? So this is the main thing you need to know. He may give you a scenario where a patient has seizures. You should always give hypertonic saline, 3% saline. If it's non-urgent, always treat the underlying cause. Okay, good. So based on that, we should, based on that, this is a scenario. 48-year-old man is brought to the ED because of seizures. Is the same scenario. During this episode, he urinated on himself. He is now drowsy and nauseated. He's drinking a lot. He appears lethargic. Physical examination and neurological examination show no other abnormalities. Laboratory studies are shown. Serum sodium is less than 120, which is severe hyponatremia. What's the next best step in management? The answer would be hypertonic saline, because this patient has severe symptoms, CNS symptoms, and he has severe hyponatremia, less than 120 sodium. Okay, good. This is a bit of a tougher question. A 60-year-old man comes to the emergency department with a history of headache and generalized fatigue. He has not vomited. He was diagnosed with small cell lung cancer, for which he finished his last cycle of chemotherapy. He appears malnourished, but is oriented to time, place, and person. He's afebrile. He's not tachycardic. He's not tachypneic. He's vitally stable. There is no edema. So he's not hypervolemic. Examination shows decreased breath sounds over the left lung. Neurological examination show no focal findings. Laboratory studies are shown in the table below. Which of the following set of laboratory findings are most likely to show in this patient's condition? So he has a serum sodium of 125, severe hyponatremia. What would be seen? Okay, so this is a case of small cell lung cancer, and small cell lung cancer usually releases ADH as part of a paraneoplastic syndrome. So this is a case of SIADH. You can also tell that it's SIADH by the fact that there's no sign of hypovolemia or hypervolemia. So the patient has euvolemic hyponatremia, which means SIADH. In SIADH, it would be a true hyponatremia, so serum osmolality would be low. So that is either B, A, or D. Urine osmolality would be high, so it's either A or B or D. And serum urinary sodium excretion would be high because you're reabsorbing all the water and leaving the sodium, because renin-angiotensin-aldosterone system is not active. So urinary sodium excretion will also be high. So the answer would be B. Okay? This is a classic case of SIADH. Low serum osmolality, high urine osmolality more than 100, and high urinary sodium excretion. Any questions for this question? Any questions about this? No? Good. Good. A 65-year-old woman is brought to the ED because her family knows that she awoke this morning with a headache and became progressively incoherent over the course of the day. Do we need to know the normal lab values? No, you don't. They'll give you the normal lab values, okay? But remember, less than 100, more than 100 urine osmolality. Less than 275 serum osmolality is low serum osmolality, okay? So this person has a headache and is becoming progressively incoherent. So she's having CNS symptoms. 3 weeks ago, the patient was diagnosed with depression and started taking sertraline, which is an SSRI. She is afebrile, normotensive, normal pulse. She's not tachypnic. She is disoriented and irritable. There is no peripheral edema. She's not hypervolemic or hypovolemic. Laboratory studies are shown. Serum osmolality is low. It's less than 275. Urine osmolality is very high, and urine sodium excretion is high. More than 30 is considered high. So what is the most likely cause of this patient's hyponatremia? So firstly, what type of hyponatremia does this patient have? Is it hypervolemic, hypovolemic, or euvolemic? And is it ADH dependent or ADH independent? Because of the urine osmolality, you know that this is ADH dependent, and there's no signs of hypervolemia or hypovolemia. So this is euvolemic hyponatremia or SIADH. The only thing which causes SIADH in all of these options is adverse effect of a drug. And SSRIs are a classic cause of SIADH. Other drugs include carbamazepine, stuff like that, anti-epileptic drugs, okay? This is the only correct option, because this is she doesn't have decreased solute intake because she's not hypovolemic. She doesn't have an intracranial neoplasm, no signs of that. She doesn't have intravascular volume depletion, mineralocorticoid deficiency. She would have hypovolemia, polydipsia. Her urine osmolality is high, which basically means it's ADH dependent. Polydipsia would cause a low urine osmolality. Okay, so the answer is A. Okay. A 33-year-old woman is brought to the ED after an episode of seizures. She is confused and unable to provide further history. Review of her medical record show that she has schizophrenia, but stopped taking all of her psychiatric medications 3 weeks ago. She is afebrile, normotensive, normal pulse, normal respirations. The patient's lungs are clear to auscultation and her heart sounds are normal. Extremities show no edema. Laboratory studies are shown. Which of the following is the most likely cause of this patient's electrolyte abnormalities? So she has severe hyponatremia with seizures, so you would give hypertonic saline. She has hypokalemia, slight hypokalemia, and nothing else. She has low serum osmolality, so it's a true hyponatremia. She has low urine osmolality, less than 100, which basically means it's ADH independent. Okay? The only cause of ADH independent hyponatremia is primary polydipsia. So the answer is E. Okay, exactly. So always look at the urine osmolality. If it's less than 100, it indicates an ADH independent cause like primary polydipsia, beer potomania, or tea and toast diet. If it's more, then you think about hypervolemic, hypovolemia, euvolemia, which is SIADH. Good. And to treat this patient, because it's a severe hyponatremia less than 120, and this patient is having CNS symptoms, you should give hypertonic or 3% saline, and that carries a risk of osmotic demyelination. Good. Now, a 32-year-old man is brought to the ED after a car accident. He was extricated after 4 hours. He did not lose consciousness and does not have headache or nausea. He's in severe pain. He sustained severe injuries to both arms, and the trauma team determines that surgical intervention is needed. Urinary catheterization shows dark-colored urine. Her temperature is 38. She's febrile, almost. She's tachycardic. She's hypotensive. The patient is alert and oriented. Examination shows multiple injuries to the upper extremities, contusions to the trunk, on the trunk, and abdominal tenderness. Here's the important part. Laboratory studies show a potassium level of 6.8. The normal is 3.5 to 5. Okay? Arterial blood gas shows a pH of 7.3 and a serum bicarbonate of 14. So she's in metabolic acidosis. EKG shows QRS complex prolongation and QRS prolongation on lead 2. Okay, so QRS widening on V2, V3, and lead 2. Which of the following is the most appropriate next step in management? So this is a classic case of rhabdomyolysis. This patient has severe injuries and muscle death, causing hyperkalemia. That hyperkalemia is leading to arrhythmias. Okay, good. So Leon says D, insulin and glucose therapy. Insulin and glucose therapy is the first line management for reducing serum potassium in a case of severe hyperkalemia. However, if the patient has EKG abnormalities, you should give a medication that stabilizes the cardiac membrane. Okay, so you should always give calcium gluconate first if the patient has EKG changes. If the patient has EKG changes, you should give calcium gluconate followed by insulin and glucose. If the patient doesn't have EKG changes, you can give insulin and glucose. If the patient has non-severe hyperkalemia, you should treat the cause. Okay, good. So a similar question, a 48-year-old man is brought to the ED because of cramping abdominal pain, nausea, weakness, and watery diarrhea for 1 week. He has a history of hypertension for which he takes thiazide diuretics. Vital signs are unremarkable except a blood pressure of 89/59 millimeters of mercury. So he's hypotensive. Physical examination shows dry mucous membranes, decreased skin turgor, crackled lips, and a capillary refill of greater than 3 seconds. His serum potassium is 2.8, the normal is 3.5 to 5. EKG shows sinus bradycardia with T wave flattening and U waves. U waves are an important sign of hypokalemia. Oral and IV potassium supplements are started and IV fluid replacement for his hypotension is initiated. However, 8 hours later, his serum potassium is still 2.9 milliequivalents. A low serum concentration in which of the following is most likely to explain this patient's persistently low serum potassium? B, exactly, yes, magnesium. So the take-home message from this scenario is that firstly, diarrhea leads to hypokalemia. The second part is that if you try and correct the hypokalemia with oral and IV potassium, and the hypokalemia is refractory, or if it doesn't correct, you should always check the magnesium level, because hypomagnesemia is the most common cause of refractory hypokalemia. Okay, so if you have in the exam, if you have a patient with refractory hypokalemia, always see his serum magnesium level and correct that first. Good. Another scenario: a 58-year-old man with Burkitt lymphoma. Is it related to the drug? What is related to the drug? No, because magnesium and potassium concentration are closely tied together. I don't know the exact mechanism, but it seems that hypomagnesemia. No, so are you saying that his hypomagnesemia is related to the thiazide diuretics? It probably is related to the watery diarrhea. Okay, and he's taking thiazide diuretics, which is causing further volume depletion. Okay, good. So a 58-year-old man with Burkitt lymphoma is admitted to the hospital for chemotherapy. Medical history shows hypertension, stable angina, and hyperlipidemia. 2 days after starting the chemotherapy, the patient reports nausea and generalized weakness. Laboratory studies are shown. His serum sodium is normal, serum potassium is 6.8, so severe hyperkalemia. He has a low bicarbonate, rising BUN. Other findings are unremarkable. EKG shows peak T waves. So again, which of the following should be employed to rapidly lower serum potassium in this patient? You guys already answered this question, which is insulin and glucose, because this question, the answer wouldn't be calcium bicarbonate, because it's not asking you what's the first step in management. It's asking you which of the following is the best to lower serum potassium in this patient, and that the answer is insulin and glucose, so E. Okay. So just to recap, hyperkalemia, if it's associated with EKG changes, you give calcium gluconate first to stabilize the cardiac membrane, then you give insulin and glucose. But insulin and glucose is the first line to lower the serum potassium level. Good. This is just a summary of potassium imbalance. You have hyperkalemia, more than, this should be reversed. Hyperkalemia is more than 5 milliequivalents. The causes, you can either increase intake like diets or IV fluids. It can be reduced excretion, such as an acute kidney injury or chronic kidney disease. Endocrine causes like adrenal insufficiency related, they usually cause hyperkalemia. Drugs like potassium-sparing diuretics, ACE inhibitors, and NSAIDs, they decrease renal blood flow, and so they can cause hyperkalemia. The next thing you should think about in hyperkalemia is extracellular shifts. So acidosis, if you have a high hydrogen concentration outside the cell, that moves hydrogen inside and potassium outside. So acidosis is always associated with hyperkalemia. Low insulin activates the sodium potassium pump, which pumps potassium inside of cells. And when you have low insulin, you have low activation of this sodium potassium pump, which causes hyperkalemia. Beta blockers, the same mechanism. The beta receptors, activation of beta receptors activate the sodium potassium pump. Their inhibition by beta blockers usually cause hyperkalemia. Extracellular release usually occurs in rhabdomyolysis or tumor lysis syndrome or hemolysis. The symptoms are always the same between hyperkalemia and hypokalemia. You have muscle weakness, decreased deep tendon reflexes, and EKG changes. The specific EKG changes, I don't think they're going to test you on that, but peak T waves in hyperkalemia and QRS prolongation. In hypokalemia, you can have U waves and T wave flattening. Diagnosis, all these investigations. You need to do an electrolyte. You need to do a renal function because AKI is associated with hyperkalemia. You need to do arterial blood gas because rule out acidosis. You need to do an EKG to see if the hyperkalemia is actually increasing the patient risk for arrhythmias. You do CK to check for rhabdomyolysis. LDH is a marker of hemolysis, and renin-angiotensin-aldosterone level activation because mineralocorticoid insufficiency or deficiency is associated with hyperkalemia. Good. If it's an emergency hyperkalemia, you give calcium gluconate, then insulin and 5% dextrose or glucose. Hemodialysis is usually the most effective, but it's not first line, okay? With hypokalemia, you can have GI loss like vomiting and diarrhea. You can have renal loss, such as with diuretics, or type 1 and type 2 RTAs or glucocorticoids. Glucocorticoids, why? Because they activate the aldosterone receptor in the kidney, and that causes potassium excretion. Intracellular shifts, that's the opposite of hyperkalemia. Alkalosis, so if you have low hydrogen outside of cell, that moves potassium inside and hydrogen outside. So hypokalemia is associated with alkalosis. Insulin and beta-2 agonists, again, the opposite of this, activation of the sodium-potassium pump. This is probably the most important thing I need you to know. Hypomagnesemia is associated with refractory hypokalemia, okay? Treatment, just give the potassium back. If it's severe, you go for IV. If it's moderate, oral. If it's very mild, you just treat the underlying cause and the patient will be okay. Okay? So hyperkalemia management again. Calcium infusion, the first part to stabilize cardiac membrane. Insulin with glucose. Usually hemodialysis is most effective, not first line. Good. Start off discussing acid-base problems. This is just a general algorithm. The normal pH is between 7.35 to 7.45 or 7.37 to 7.43. If it's less than 3.5, it's acidemia. You always look at the PCO2 next, okay? So just to keep it straight in your head, look at the pH. If the pH is down, look at the CO2. If the CO2 is down, so the pH and CO2 are going in the same direction, it always means metabolic, okay? Similarly, if the patient is alkalotic, you look at the PCO2 next. If the pH is up and the PCO2 is up, they're both going in the same direction, it's always metabolic, okay? Now, you've diagnosed metabolic acidosis. The next thing to do is calculate the anion gap, which is sodium minus chloride minus bicarbonate. If it's greater than 12, you have a high anion gap metabolic acidosis or HAGMA. If it's less than 12, you have a normal anion gap metabolic acidosis. For both of them, the next step is to calculate compensation. And that is done by a formula called Winter's formula, which is 1.5 times bicarbonate concentration plus 8 plus minus 2 for only for high anion gap metabolic acidosis. So again, only for high anion gap metabolic acidosis, you do something called a delta-delta. What you do is you subtract the anion gap, the high anion gap from 12. So let's say the anion gap was 18, you subtract it from 12. So the delta anion gap would be 6. Then you add the 6 to the patient's bicarbonate. If that answer is less than 24, the patient has a tertiary acid-base problem, which is normal anion gap metabolic acidosis. If it's greater than 24, he has a metabolic alkalosis. So the delta-delta is only used for high anion gap metabolic acidosis to check for a tertiary problem, okay? Good. Then you move on to metabolic alkalosis. So pH is up, PCO2 is up, going in the same direction, metabolic alkalosis. Respiratory compensation is calculated by delta PCO2 equals 0.7 times the change in bicarbonate. So metabolic alkalosis, bicarbonate rises to 32 from 24. The change is 8 times 8. 0.7 times 8 equals 5.6. So the PCO2 should increase by 6. Okay, by 5.6. The easy way to think about respiratory problems is if pH and PCO2 are going in the opposite directions. So if pH is low and PCO2 is high, they're going in the opposite direction. The primary problem is respiratory. If pH is high and PCO2 is low, going in the opposite direction, the primary problem is respiratory alkalosis. For compensation, always draw this table, all right? For acute, just remember that every 10 change in PCO2 would cause a 1 change in bicarbonate, okay? And chronically, every 10 millimeters of mercury change in PaCO2 would cause a 4 change in bicarbonate, okay? Good. So this is quite an easy question. A 42-year-old man is found unconscious in the subway station. He is brought to the ED, where cardiopulmonary resuscitation is performed and IV glucose and thiamine are administered. His arterial blood gases on room air are shown. So he has acidosis. pH is less than 7.2. PCO2 is low. So pH is low, PCO2 is low. They're both in the same direction. It's a metabolic acidosis. That's confirmed when you look at the bicarbonate. Okay. Now, you diagnose metabolic acidosis from this. What's the next best step in the diagnosis of this patient's acid-base status? Tell me. Yeah, it's quite easy. Always, when you see a metabolic acidosis, the next step is to calculate plasma anion gap, which is sodium minus chloride minus bicarbonate. Good. Then you think of, this is again just a review, then you think of causes of different acid-base problems. I've shown you the algorithm. When you think of causes, for high anion gap metabolic acidosis, high anion gap is always caused by increase in acid. Those acids can be endogenous, like keto acid in DKA, lactic acid as in lactic acidosis, and uremic toxins, such as in AKI or CKD. Those toxins can be exogenous toxins like methanol, like glycols, like aspirin, like acetaminophen. Okay, aspirin is important, acetaminophen is important. These ones are also important, okay? So endogenous acids, rule out DKA, rule out lactic acidosis, rule out kidney injury. Then you think of exogenous acids like methanol, ethylene glycol, aspirin. For normal anion gap metabolic acidosis, you always think of loss of bicarbonate, either in the GI tract through diarrheas, either acetazolamide, which inhibits carbonic anhydrase, loses bicarbonate in urine. GI fistulas, the same concept. Type 2 RTAs, they block bicarbonate. They're associated with a deficiency of a transporter called sodium bicarbonate cotransporter. Bicarbonate is lost in urine, okay? Or you think of decreased acid excretion, such as in normal saline infusion. In normal saline, you're giving the guy chloride. So that increases the negative charge in the serum. That drags hydrogen out of cells, which causes a metabolic acidosis. Type 1 and type 4 RTAs or renal tubular acidosis, Addison's disease. The important one is always diarrhea, GI fistulas, okay? These ones are important for you. Metabolic alkalosis, you always calculate urine chloride. If the urine chloride is low, that means the patient has hypovolemia and he has something called contraction alkalosis. To correct this, just give the guy fluids and the metabolic alkalosis will correct. If it's a high urine chloride, then you think of other electrolyte abnormalities like magnesium, potassium, or calcium deficiencies, or hypercalcemia, sorry. For respiratory acidosis, the easy way to think is hypoventilation. For respiratory alkalosis, the easy way to remember it is hyperventilation. What could cause hypoventilation? Either a central depression, either a musculoskeletal problem like chest wall fatigue or musculoskeletal diseases like ALS or amyotrophic lateral sclerosis, ankylosing spondylitis, multiple sclerosis, myasthenia gravis, or a lung disease like COPD or asthma, okay? For hyperventilation, usually a panic attack, anemia, high altitude, salicylate poisoning. So aspirin acutely causes respiratory alkalosis, chronically causes high anion gap metabolic acidosis. Okay, good. Or you can have PE, pulmonary edema, pneumonia. They usually cause the patient to become dyspnea, or they usually cause dyspnea and the patient's tachypneic or hyperventilating. Usually cause a respiratory alkalosis. So hypoventilation acidosis, hyperventilation alkalosis. Okay. Again, this is just a summary for all the causes. Good. So 2 hours after undergoing laparoscopic gastric bypass surgery, a 44-year-old man has pain at the site of surgery and has vomited twice in the past hour. He has hypertension, type 2 diabetes, and hypercholesterolemia, which he takes a bunch of medications. He takes acetaminophen. He's morbidly obese. His temperature is 37.2. He is tachycardic. He's tachypnic, and he is normotensive. Physical examination is unremarkable, except diffuse tenderness to abdominal palpation. Bowel sounds are reduced. Laboratory studies and ABGs are shown. So in terms of electrolyte abnormalities, he doesn't have many. He has high BUN and borderline high creatinine, which could signify that he has some sort of kidney injury. In pH, he has acidosis, acidemia. His PCO2 is low. So pH low, PCO2 low, which means metabolic acidosis. Look at the bicarbonate. His bicarbonate is 14. That confirms the metabolic acidosis. Which of the following is the most likely cause of this patient's acid-base status? A. Okay, so now calculate the anion gap for this patient. Sodium is 136. My screen isn't showing this properly. Just 1 second. Okay. So calculate this patient's anion gap, and you will see that sodium is 136, fluoride is 98, bicarb is 14. So 98 plus 14 is around 112, minus 136 minus 112 is 24. So this patient has high anion gap metabolic acidosis. Okay. Okay. So what are the different causes of high anion gap metabolic acidosis? You can either think of endogenous acids like DKA, lactic acidosis, or uremia, or you can think of exogenous acids like methanol, or glycol poisoning, or aspirin poisoning. Okay, good. But so does this patient have a history of DKA? He has type 2 diabetes. Type 2 diabetes doesn't cause DKA, and they haven't told you that this patient has elevated keto acids. So it's not DKA. If you look at this patient's PO2, he has hypoxemia, okay, or hypoxia. That indicates that this patient is developing lactic acidosis. So the answer would be D, okay? The diabetic ketoacidosis, they haven't given you a scenario for that, okay? Vomiting usually causes metabolic alkalosis. Alcohol withdrawal, it causes seizures. It could cause lactic acidosis, but alcohol withdrawal is not the cause of this patient's acid-base status. Dumping syndrome, you will do this more in GI, is a complication of gastric bypass surgery. It usually doesn't cause high anion gap metabolic acidosis. So this patient is having lactic acidosis because of hypoxia, okay? The answer is D. Good. The next question, a 70-year-old woman is brought to the ED by her daughter for, okay, good. A 70-year-old woman is brought to the ED by her daughter for a 2-day history of non-bloody diarrhea. The patient has had 8 to 10 bowel movements and has not vomited. She has many comorbidities, is taking a bunch of medications, including furosemide, thiazide diuretics, lisinopril, metoprolol, dapagliflozin. She appears ill and sleepy. She is afebrile, tachycardic. She is tachypnic. She has normal blood pressure right now, but on the lower side. Pulse oximetry shows an oxygen saturation of 97%. Physical examination shows dry mucous membranes. ABGs are shown. So her pH is low. PCO2 is borderline low. Okay? Is borderline normal, pretty much. Bicarbonate is low. So bicarbonate is low and pH is low. That more in line with a metabolic acidosis. Then, if it's a metabolic acidosis, you calculate respiratory compensation using Winter's formula. So what you would do is 1.5 times 16, which is 24, plus 8, 32 plus minus 2. So 30 to 34 would be his expected PCO2, but his PCO2 is 39. So what does that mean? What's the answer? So the answer is E, exactly. So he has metabolic acidosis with respiratory acidosis or uncompensated metabolic acidosis. So always when you see, always follow that algorithm. Metabolic acidosis, Winter's anion gap. If it's regardless of whether it's high anion gap or normal anion gap, calculate compensation using Winter's formula. Only for anion gap, use the delta del. Okay. Now, 54-year-old man is brought to the ED by his wife because of high fever and confusion for the past 10 hours. His wife reports that 1 week ago during a trip to Guatemala, he underwent an emergency appendectomy, or he had removal of the appendix. He is febrile, he is tachycardic, he is hypotensive, he is disoriented. Physical examination shows a surgical wound in the right lower quadrant with purulent discharge. So he has an infected wound. The skin is warm and dry. Serum studies show a sodium concentration of this should be 137. This should be 3.7. So serum sodium is normal, potassium would be normal. Lactate is high because the normal is 0.5 to 2.2. This person has a lactate concentration of 3.5 milliequivalents per liter. ABG on room air is shown. So let's see here. He has pH of 7.24, acidosis D. Okay. And he has, so it's the same scenario, it's the same ABG, and he has uncompensated metabolic acidosis with concomitant respiratory acidosis. The only thing which could cause this is respiratory muscle fatigue. So likely this patient was hyperventilating and his PCO2 was going down, but because perhaps his treatment was delayed, he developed respiratory muscle fatigue and started to develop hypoventilation, which caused the increase in PCO2 and a concomitant respiratory acidosis. Okay, good. A 60-year-old man is brought to the ED due to fever, chills, and confusion. The patient was fishing in the ocean yesterday and cut his foot on a jagged rock while wading through shallow water. He was unable to clean the wound right away, and overnight it became increasingly red and painful. The patient was awakened several times by fever and chills, and this morning his wife found him disoriented. Temperature is 38 degrees Celsius. He's hypertension, tachycardic, tachypneic. Heart sounds are rapid and regular. Breathing is fast and shallow. The right foot shows a laceration with purulent discharge with and erythema spreading to the shin. Which of the following best describes the acid-base status of this patient? The mixed metabolic acidosis and respiratory acidosis. Okay, so let's see. His pH is low. His PCO2 is high. His bicarbonate is low. This patient is developing, it has signs of septic shock. He had an infected wound and he now is hypotensive. That's indicative of septic shock. Okay, so septic shock usually causes elevated lactate or lactic acidosis. So this patient would likely have an elevated anion gap metabolic acidosis. So let's calculate it. Bicarbonate is 12. So 1.5 times 12 is 18 plus 8, 26. Plus minus 2. So 24 to 28 should be his expected PCO2. But likely this patient is decompensating and developing, and because his breathing is fast and it's shallow. Even though he's tachypneic, his breathing is shallow, which means the alveoli, the carbon dioxide is not getting cleared. So he's hypoventilating actually, despite the tachypnea. So this patient would have mixed metabolic acidosis and respiratory acidosis. Good. So this is the last scenario. A 56-year-old man comes to the ED due to a 2-day history of fever, chills, shortness of breath, and productive cough, symptoms of pneumonia. The patient has had an episode of vomiting while in the ED. He has no prior medical conditions and takes no medications. He has smoked for several years and occasionally drinks alcohol. He is febrile, hypotensive, tachycardic. Repeat blood pressure measurements after administration of 2 liters of saline show a blood pressure of 120 over 80 millimeters of mercury. Leukocyte count is 16,000 millimeter cubed. ABG on room air is shown. What is the acid-base disorder in this patient? Sorry, what was the previous answer once again? We'll go back to that. Okay. Okay. C. All right, so what's this? He has a high pH, so he has alkalemia. He has a low PCO2. Okay, so that means pH and PCO2 are going in the opposite direction, which mean respiratory alkalosis, right? Yeah, exactly. Respiratory alkalosis. Then the next step in respiratory alkalosis is to calculate metabolic compensation or renal compensation. The way we do that chronically is that for every 10 change in PaCO2, you would have a 4 increase in bicarbonate or a 4 change in bicarbonate. Because this patient is alkalotic, his PCO2 is down. Then you would expect bicarb to decrease in order as a compensatory mechanism. So if this patient's PaCO2 is, or change in PaCO2 is 10, his expected change in bicarbonate would be 4. So his expected bicarbonate should be 20, but it's 24. So that means this patient had a respiratory alkalosis. Exactly. This patient had a respiratory alkalosis with concomitant metabolic alkalosis. Okay? So the answer would be H, uncompensated respiratory alkalosis. Okay, and that's it for all our scenarios. Any questions for acid-base electrolytes or glomerular diseases? Could you go to the acid-base summary slide, please? Sure. This one? You want me to explain it again? No, just wanted to see. Okay, well, we will send the presentation. I'll send you guys the presentation and you can have a look at it, okay? How can I differentiate between compensation and a mixed disease? So let me give you an example. If a patient has a high anion gap metabolic acidosis, and through Winter's formula, you calculate that his expected PCO2 should be 30, and his actual PCO2 is 30, that means it's compensated. If his expected PCO2 is 30, but his actual PCO2 is 25, that means he has a concomitant respiratory alkalosis. If his PaCO2 is 35, that means he's not compensated and it's actually a concomitant metabolic respiratory acidosis. So always look at the value, then compare with the patient's actual value. Okay? For the question we did, it was respiratory alkalosis. So why didn't we use 2 and use 5? Okay, that's a good question. So acute the patient we discussed the last case, he had a presentation of 2 days history. That indicates a more chronic thing. Okay, they would always kind of give you a chronic compensation. I don't think they would give you an acute respiratory alkalosis with and ask you to calculate the compensation. Most of these questions are from UWorld and AMBOSS, and they usually give a history of either hours of symptoms or days of symptoms, which basically means that this patient should be chronically compensated. Okay, so you use always 4 or 5. And usually the range is whatever value you get is plus minus 3. Okay? So it depends on the time. Let me show you here. Yeah, so 2 days history. So if this was an hour history or something, then it would be acute. But if it's several hours, more than 6 hours, let's say, more than 10 hours, or even days, you usually go for the chronic measurements. Okay? What's confusing me is for every 10, there's a drop in 4. I'm confused as to how to apply the numbers in the table. Okay. Okay, so let me give you an example. Let's say his PCO2 is 30 here. Okay. What makes sense to you should be the compensation for this patient. He has respiratory alkalosis. So the bicarbonate should decrease because the body wants to decrease the blood pH. How the body will do this is by getting rid of the bicarbonate. So if you go for the chronic measurement here, his bicarbonate should decrease by 5. So it should be, if you're going from 24, it should be 19. On the other hand, if it's respiratory acidosis and his PCO2 is 60, let's say, and his bicarbonate should be around 32, because the body is trying to save bicarbonate to try and raise the pH back up. Okay? So it's always so the way you can think of it is that in respiratory acid-base problems, the bicarbonate should increase in the same way as the PO2, in the same direction as the PCO2. So the PCO2 is increasing, the bicarbonate should increase. If it doesn't increase by the measured amount, then it's a concomitant metabolic disorder. Okay? Okay, good. Everything clear? Okay. And that's it. Thank you.